Hypertension was the leading risk factor for death worldwide in the United States. By the way, is also the biggest bottom line expense. How the heck do we tell people they have a silent killer? It is falling to employers to provide their employees with clear health information, because employers remain one of the most trusted sources of health information in the country.
Healthcare in America isn't just complex, it's chaos, with the information and power stacked against employers and patients. On Margin of Care, we set out to rebalance that scale. On this episode, we're sitting down with one of the nation's most influential thinkers on medical innovation, public health, and policy. Dr. Vin Gupta has the kind of resume that honestly makes me feel a little bit lazy. He's currently a practicing pulmonologist at Virginia Mason Medical Center, the lead officer of the U.S. Air Force's Critical Care Air Transport Team, a managing director of health innovation at Manat Health, and he's a member of the board of directors for the National Lung Association. Before all of that, Vin served as the chief medical officer at a little company called Amazon, and even worked with Apple's clinical team to help develop the Apple Watch. We are very fortunate that Vin made the time to sit down and talk with us about the future of medical innovation and how those advances are going to shape the industry moving forward. This is what comes next.
Hey, Vin, thanks so much for being with us today. I want to start out just a little bit talking about your background and some of your career pathing. So for those of you who don't know Vin's background, he was at one point a lead officer for the U.S. Air Force Reserves. What have you carried forward from that experience into some of the careers that you've sort of moved into?
I appreciate the tip, because I think people misunderstand and or don't really have a lot of exposure, just as things have changed in society to one, the military, but also military medicine and why it's so important. I randomly found my way to the military. My first day in college was 9/11, and I was 45 minutes south of New York City when it happened. And a lot of my generation at that moment actually went into ROTC, joined in an infantry capacity, very much frontline, active duty. I was very convicted to do something very similar in terms of service, but for me, there was always going to be a health element to it. So I, meandering path, found my way to military medicine, and they helped put me through medical school. And so I would say for everybody that's listening, that's maybe considering a health professions track, if you've been thinking about ways to subsidize that, because it's never been more expensive in many places, you should give it a look. And I'm happy to provide that counsel if folks want to reach out. But what it started my path towards technology was actually my exposure on deployments to technology in the bay of a C-130 or a C-17, doing runs, being deployed, where I think people don't realize that the U.S. military has some of the greatest technology, whether it's battlefield warfare related technology, which I have a little expertise in, or whether it's actually direct patient care, bedside care. And so that's where I got my start in understanding wearable technology, things that you could deploy at 30,000 feet and try to help save somebody's life. And again, it's such an enabling, empowering platform to be uncomfortable, to be willing to take greater risks. And so it was an accelerator for me.
Yes, I would imagine some of the situations that you may have been in, like heightened pressure, like you probably, as you transitioned into being ICU physician, like that pressure is still there, but that might have trained you pretty well for some of the situations you got into.
I say this to me in my future roles at Amazon and just, wearing different hats across the healthcare continuum, you have to be adaptable. And to be vocally self-critical of my profession, I think there's a rigidity to medicine. And we know one way because we were taught one way, and we have certain expectations after 15 years in some cases of training of how things should operate. And if they don't operate that way, and by the way, they're not operating that way because patients in a really good sense are now more empowered with accurate information should they have the right tools at their fingertips through generative AI platforms that are direct to consumer. They have much better information at the point of need. So what they need from us as doctors has fundamentally shifted. But I found myself being able to adapt to that reality, to be able to work with non-medical experts that know how to build a product, to work at a big tech company, because if you're in the military and you're not adaptable, you're not going to last long.
You've got a ton of stuff going on. You're wearing a bunch of hats right now. Like, why still do work in the ICU when you don't have to do that anymore?
I think if you're a provider, I've been a clinic leader across big tech companies for now over 7 years. And I don't know how I do my job for an Apple, helping them build an Apple 6 watch, or an Amazon, if I wasn't still caring for patients at the bedside at least part of my time. I think it keeps you humble. keeps you understanding what the actual problems are from a patient experience standpoint. Yeah. And also, by the way, from a provider experience standpoint, I think it's really easy to talk in abstractions about provider burnout. The healthcare system is terrible. Everybody has their own riff on it. But then if you're not still experiencing it and still in the weeds with it and still with your fellow peers understanding that, I think one, you lose a sense of it, in my opinion. And two, I think you also lose some credibility to be able to talk about these things with authority. And so to me, it's important just to be effective. And I also spent 15 years training to be a pulmonologist. I think the world needs more of us, not less of us, given the burden of disease from pulmonary conditions, whether it's climate and health, whether it's the next pandemic, everything in between. So I think it's really important to stay clinically active for a variety of reasons.
I'd love to kind of just dig in a little more. Like you mentioned sort of the parallel of what you were doing with the Air Force Reserves and some of the work that you're doing in ICU, and then sort of transitioning over to industry, to Apple, to Amazon, et cetera. Like what did you sort of find as you were practicing within ICU that you were actually able to kind of take or like design improvement ideas when you went to Apple, when you went to Amazon?
The last 3 years have focused a lot on Amazon Pharmacy. And just as an example, I do think that there is a disconnection where no one wakes up in the morning and says, gosh, I gotta transfer over my meds to Amazon Pharmacy. You don't want to think about pharmacy unless you're sick or, you're on chronic meds and you need refills, but it's not a lovable experience. It's not a delightful experience that you actively want to engage in. And for a company that pretty much operates historically in the wants and sort of desiring purchasing category, people go there because they want to be happy. They want to buy something, a gift or something that, to spend their excess cash on. They don't necessarily wake up saying, I'm going to be a customer of Amazon Pharmacy. So how do you build that organic demand? How do you shift people to say, this makes sense? As their chief medical officer, a lot of how we framed why we matter and why coming to us would make sense is really focused. It was a lot of framing on the golden window of therapy, which I focus a lot on in the ICU, which is if somebody is sick, time is of the essence. And I think we never replicate, even though we should in the at-home environment, we never replicate speed. People wait days and days if they're medically high risk before they go and get a test for flu or COVID, before then they seek out treatment. And you only see speed when you show up to an emergency room. But there's nothing, there's a randomness there on, is that 50-year-old with a couple of comorbidities, is he going to show up to an emergency room or an urgent care with the same clinical presentation, same flu A positive test? If he does, versus if he stays at home, he's going to have a very drastically different experience. Time to treatment is going to look a lot different. So why am I telling you this? A lot of what we framed over the last 3 years, and I'd say a lot of it has been formed by my bedside experiences in the ICU, has been, what are real patient challenges? What are use cases in which Amazon Pharmacy makes sense to be thinking about? And how do we talk about speed as something that's clinically impactful, not just because Amazon's good at speed through Prime, but why does it matter clinically? And a lot of our speed framing, or the way we've framed our value add from the speed perspective, has been talking about the golden window of treatment. And I'm not saying they wouldn't have arrived at that framing at some point down the road, but when I see that every single day and I'm having to be out there in growth conversations and convince my peers that, hey, we're onto something new, they don't want to hear marketing material, making healthcare easy and convenient and cheaper. Whatever the riff is, that's not compelling at some point to a health system or to a savvy clinician that says, what, that sounds great, but does it mean something good for my patients? And so I think getting to the bottom line, a lot of that's been informed by what I've seen at the bedside.
I want to just unpack a little bit around consumer expectations. So you mentioned the fact people come to Amazon because they want to buy something that brings them joy, or they go to the mall to buy something that brings them joy. They don't get joy from accessing healthcare typically. We're seeing right now that I would say anecdotally, typically people that are younger, that are in their 20s and their 30s, they're not really focused on prevention. They're not really focused on screenings. I was in my 20s, I'm in my late 30s right now. Most of the people that are in my age group don't think about going to the doctor every year to get their preventive screenings, to get their lipid panels, their metabolic tests, et cetera.
Yeah.
But at the same time, cancer risk is increasing, CV risk is increasing, et cetera. So as you sort of think about what you were doing at Amazon Pharmacy, as you sort of think about this sort of challenge of actually getting younger people to engage in these types of screenings to try to drive down the risk of these chronic conditions. How should employers really think about evolving the patient experience to drive more people to get those screenings, to get that preventive type of care?
Some of my closest colleagues at Amazon have been and are colleagues in Amazon Employee Benefits. And I give them a lot of credit because they're soon to be the largest employer in the country. And I think they're constantly trying to push the envelope on what makes sense. We have a huge employee base. We can't do everything. We introduce a new tool or a new screening study or a new coverage for a therapeutic. It's an entry on the P&L that they weren't expecting, and it has significant impacts. So we have to be smart and thoughtful. And yet, exactly to your point, employers remain one of the most trusted sources of health information in the country. And you could argue at this moment when, say, the podium of the CDC and the NIH over the last 5 years has been eroded from a trust standpoint, regardless of who's in office, what party, it is falling to employers to provide their employees with clear health information, to make sure they're engaging in their benefits, to direct folks to the highest quality providers to give them the care that they deserve. But I think the thing that I don't think anybody has figured out, and I'll say this, again, having worked a lot with large employers, especially my own with Amazon, I do think we're still reliant on outdated screening tools. So you talked about screening tools. At the end of the day, I think the number is about 45% of people never sign up for, say, a PCP appointment. And between the ages, I think it was the sandwich generation, 35 to 54 years of age, almost half of them don't even sign up for a covered benefit like, hey, go to your PCP that we're offering for free. And Gartner, if they're partnering with Gartner, will tell you which one is the highest quality. So just make the darn appointment and get your screenings. Half of US adults get their health insurance through their employer. Almost half of those never see a PCP. I'm sure the larger numbers here across the country in terms of poor health engagement are even bigger than that. If we're just talking about those that are relying on their employer for health information and health coverage, we're talking about a massive number of people that remain unengaged. I'll say at Amazon, we focus so much on services. Clinical services, once you know you have a problem, we want to make that A+ experience from a patient experience, customer experience perspective. Pharmacy, we want to build the world's most engaging pharmacy. I think we're far on that track. A lot of progress. But if you don't think you need healthcare because it's a grudge purchase, as we were talking about earlier, because you don't feel sick, or because you don't want to deal with it because you have preconceptions, which, by the way, is a majority of adults, working age adults.
Or it's not convenient, or
it's not convenient, yeah, or whatever it is, you're not going to engage with it in the first place. And I think part of the problem is we don't have great screening tools to tell somebody. There's a reason hypertension, for example, is the leading risk factor for death worldwide in the United States. I always talk about this. How the heck do we tell people they have a silent killer so that they do engage with their employee benefits? It's a problem of engagement in understanding what's wrong with your body. And nobody wants to put the cuff on. We've done a lot of conjoint surveys because Amazon is working on biometric scans or contactless. Get a quick scan, understand what's wrong with you, get a BP, get a heart rate, all the things. And what we realized is even amongst hypertensives that were on medications, nobody liked the idea of 30 seconds of getting your arm squeezed because it's an unpleasant experience and it requires friction. Something so simple. I think a lot of the PCPs out there, very well-intentioned, think if I'm going to send my patient home or, an employee home with an Omron blood pressure cuff, nothing wrong with the company or with the cuff, that they're going to do what they're expected to do. And most just don't. And that's the fundamental problem.
If I kind of uncover some of the things that I heard you sort of prioritize, you're talking about hypertension and obviously that being sort of a silent killer. The reality is employees, they've got short attention spans. They've got a lot of other things going on. They've got their jobs, they've got their families, and the attention span is limited right now. If employers were really going to hone in on one or two things that we got to get communication on this right, if we're trying to drive overall health and well-being improvement in our population, where should employers focus?
I'm biased here. I'm a pulmonologist, and I think there's two areas, and I deal in the spectrum of chronic disease. And so if we're talking about what we need to be messaging on, I think the reality is 40% of people do not know that they have high cholesterol across the country. 60 million adults, Kirk, currently have stage 2 hypertension, don't even know that they have it. There is a reason that coronary artery disease, people coming into my ICU with a heart attack, remains the number one killer for US adults. By the way, is also the biggest bottom line expense for employers that are footing the bill. the return on investment, they're not experiencing the return on investment for these employees, investing in these healthcare benefits for a majority of their employees that then come in with these downstream significant health consequences. And so we are not getting the types of reminders I think that we need for short attention spans on the stuff that really matters. And so the information environment's chaotic. I don't think we focus on, hey, make sure you get a cholesterol panel once a year. If there's nothing else that you do, that you just simply get your blood pressure checked once a year. If we just did those two things, and perhaps innovated on, hey, what is the blood pressure test that we're talking about? Because there's a lot of ways you can do it at the wrist, cuffless. There's a lot of ways you can get your lipid panel checked that doesn't require venipuncture now. It's just, there's devices that you actually just attach to your arm. They're clinically validated. You twist it, it's painless, gives you 500 cc's of blood. You send it in.
So that's like DIY at your house.
This is DIY at your house. There's different ways to get screenings done now that I think the awareness is incredibly poor, that are FDA cleared or approved or are working towards that. Where I think innovative employers are saying, hey, how do we think about this differently? Because something differently has to be done here. I do think it's better communication and omni-channel approaches to communication. Absolutely. And I'm sure, I know a lot of employers are trying that. But I think it's different tools. Let's look at the numbers again. The leading oncologic killer of US adults in the United States is lung cancer. Lung cancer. Far and away worldwide as well. 95% of people that qualify for a low-dose CT scan because they have a smoking history or whatever it may be, and it's covered through their employee benefits, 95% of people don't do it. I'm on the board of the American...
Because they're scared?
It's because they have to schedule an appointment, they have to take time out of their day, or they don't know about it, or there's friction. It's just hard to do. And so now we're moving towards a paradigm, again, thinking about new tools for diagnosis where you can get a biomarker test. You can just do a blood collection at home, painless, no venipuncture, and now send it in. And there's now biomarker assays better than Grail, by the way. I know some people think, oh, is this Grail? Grail's good, and nothing wrong with Grail, but there's other much more sensitive tests out there leveraging our immune system to detect early stage pancreatic cancer, early stage lung cancer. What I'm saying here is we're in a new paradigm where it's not just about better communication and awareness, that's critical, but it's also about offering then a better way to get screened. And if you're asking me, what does every single employer need to be thinking about, is how do we actually do early intervention smartly, thoughtfully, utilizing the tools that exist today? I guarantee you most employers don't know that a lot of these tools exist in the first place.
So I just, by chance, got an outreach a couple of weeks ago by one of the local health systems where I'd gone and saw a GI doctor, and they said, hey, we're doing this clinical study right now with a company called Helix. We're doing DNA testing right now. Like, I'd love to have you come in and do a DNA test. And I sat there with my wife. I was on vacation. We were in Florida, and I get this email. I'm like, do I want to know if I'm at heightened risk for colon cancer? Do I want to know if I'm at heightened risk for, hyperlipidemia?
Hypercholesterolemia.
Thank you very much. And I thought there for a couple minutes. I'm like, yeah, I guess I should do this. I should get it. But like, how should people be thinking about that when they're offered to be able to do these types of these DNA tests right now? And how should employers be involved potentially in that as well?
We're in the space where I think the price point is going to be very high up front. We're seeing that again. It's hard for employers, I think, to be thinking about, especially large employers. Gosh, am I going to cover the latest biomarker assay for the next sort of multimodal early cancer detection test? Because if I do, that's hundreds of dollars just per employee. And maybe for some, I have to do it every year. It's a lot of money. And so I understand we have to be thoughtful here. Price points, though, I think will be coming down as more competition, more new entrants. So to me, this is sort of a 10-year arc. How do we think about this over the course of the next 10 years? Just can't keep doing the same darn thing. I mean, Kirk, we're in a space with proteomics, genomics, metabolomics, where you can imagine somebody's going to understand their overall risk for cancer based on what they eat, their underlying genetics, how much they exercise, the environment around them. They're going to be able to have a game plan for an individual game plan. I'm not saying now, but over this is where I think the world is going over the next 10 to 20 years. How often should I be getting screened for lipid panels? How often should I be getting a Cologuard test for, maybe this next generation biomarker test for colorectal cancer screening? Because, it's probably different. It should be different for you than it should be for me. Our risk for certain things probably looks different based on how we live our lives and our underlying genetics. And the fact is we have a one-size-fits-all approach from a United States Preventive Task Force guidelines are one-size-fits-all versus personalized, and it doesn't actually make any sense. Here we are talking about personalized risk, personalized medicine, all the things, but here we're also saying there's one paradigm for screening, and it's the same for all of us. How does that make any sense? And so we are entering a space, and I think this is going to be good news for employers, where we'll be able to identify the highest risk demographic that will need the highest, probably most robust set of services, a different communication strategy, where you're communicating with them potentially differently than you're communicating with your healthier, lower risk populations. I think we're going to have to figure out a way to stratify the employee base proactively, not after stuff has already happened, to say, hey, we know that these employees have opted into sort of next generation proteomic screening. They're willing to share their data, or, how do we think about sort of data acquisition in an anonymized way? So we've identified a cohort of employees proactively that we think might need, say, coverage of Wegovy for 2 to 3 years to get them into a better sort of baseline health equilibrium, versus, say, the person that we think is less risky based on what we understand of their profile. We're going to offer them something potentially different. We're entering a world where we have new Alzheimer's treatments, we have new GLPs, we have new precision therapeutics. We cannot expect that employers and government lives and commercial payers are going to be able to cover every latest, greatest innovation. We need precision benefits for this precision medical era that we live in.
So I'm glad you brought up GLP-1. So I spent about 1.5 years at a GLP-1 company. It was sort of before its time. Like, it was before all the marketing was out around Ozempic, Wegovy. We were actually getting into employee benefits consultants' offices and having to actually educate them for the first time about these GLP-1s. I remember some of the feedback, like, we don't have time to talk about this. It's not going to be important. Like, we're focused on other stuff, right?
Sure.
Obviously,
sure.
Fast forward to now, and it's one of the biggest topics that's out there. Seemingly, they're wonder drugs. Not only are they helping people treat their overweight conditions and their obesity, but they're also benefiting cardiovascular health. We're starting to hear things around improvements in dementia risk, improvements in addiction risk, et cetera, et cetera. So I guess first and foremost, like, as a physician, how do you feel about GLP-1s?
They're extraordinary. And by the way, they're NIH funded. And I'm not here to make a statement on the NIH, but what I'd say is it's important for people to realize across the country, we have diverse points of view, that GLPs would not exist today were it not for seminal research funded by the NIH 25 years ago. That the time course and the arc of innovation for these new therapeutics can take decades, as you know, and it's been American taxpayer funded. And I worry about this era that we live in, where this new Alzheimer's treatment that got reported on yesterday, now we're seeing delays in potential of funding for the next sort of iteration of trials. We need to have context on why we have all these amazing tools. It takes time. It's all taxpayer funded, high risk, high reward. I'd argue that GLPs we are just scratching the surface one of their access. As we get oral versions, I like the idea of transitioning somebody that's on an injectable. That's higher cost because, by the way, it's harder to dispense. It requires cold chain, harder to dose. People don't like to inject themselves. Once we get them off injectables and maybe wean them to an oral maintenance medication, Pfizer and others are developing an oral version, less effective, but still good. Price points can be lower. People are more willing to take it over time. And maybe it becomes the new sort of panacea for cardiovascular health, where it's replacing an aspirin, it's replacing a statin. Boom, you just have to take a once-a-day GLP. I'm speculating, but I've seen some of the early data on the oral versions, and you start to wonder, well, gosh, do we have the opportunity to eliminate polypharmacy? Because it seems like somebody that takes a GLP goes from being hypertensive to no longer being hypertensive. They shed weight, their insulin dependence reverses. Maybe they don't need that aspirin. So is this a way to reduce polypharmacy, get them on something that in totality, once we have orals, will be cheaper? It's an extraordinary drug. I think there's so much, though, Kirk, that we don't know about it. How long do you need to be on it? I got to say, I'm allergic to docs and industry people on the manufacturing side that say you need to be on a GLP lifelong. I think that's irresponsible messaging. We have no data to show that. And here we are coming to employers and government payers saying, hey, you got to cover this for everybody, by the way, forever. And I think there's financial incentives for certain people and entities to say that. I think it's wrong. We know from Epic research that over 50% of people that start a GLP on day one, at day, say, 700, about 2 years in, can safely wean off without losing the gains if they have certain things in place, all the usual things, lifestyle changes, yada, yada. But it's to say, we live in a world where the FDA is being pressured Two, if the safety data is there and if there's efficacy data, they're going to start to approve things without sort of the fullness of time to understand things like when can we deprescribe. We're going to have all these tools in place, accessible to patients. Pharmaceutical companies are going to be marketing it endlessly. Press release, science by PR. Patients are going to demand access, and it's going to be on employers to say, well, what do I do? And this is where I think we have to understand the FDA is now focusing on post-approval patient registries to understand, hey, how long do you need to be on these medications? Who can deprescribe? But this is the world that we live in. Our regulatory environment now has all these tools in place that us as clinicians are trying to figure out on the fly. Well, how do I adopt this? How do I utilize it? And what can I do? And when can I actually get my patient off of it? Not everybody needs to be on these medications lifelong. And that's been a message that's been said to patients, to large employers across the country. And I think they're rightfully pushing back and saying that doesn't make sense.
What about, so in terms of just sort of FDA approval from like a BMI perspective? I think the BMI approval is down to 27 with underlying comorbidities. Yep. But I think what we're also seeing is employers are spending a ton of money, $1,500 a month on one of these medications.
Yeah.
One of the things that I used to talk to consultants about and employers about is like, wouldn't it be great if we could just kind of start out by offering these meds to people that have a BMI over 45 that are costing the plan $100,000 a year? But then you start talking about the challenge where if you start to limit BMI range, then the PBMs start to take away rebates and the disincentive is in place too. So when you think about just like the appropriate type of population and really what employers and benefits advisors, et cetera, are actually pushing for, what kind of guidance would you have?
I have deep experience on this, working with one of the nation's largest employers where we wrestle with those exact questions. And I think the problem here is if you gate it to a BMI, let's say you said 45, let's take that.
Yeah.
Then you're operating in a space where why wouldn't you just do bariatric surgery anyways? Because maybe that's more clinically indicated. And then you're limiting access so drastically that any goodness and sort of the spirit of the program, I think, gets lost. And I see your point that here, these are the highest spenders, they're in the hospital, there's going to be some ROI here. But I do think at some point you're saying severe sort of morbid obesity, but on the very sort of the most severe levels, then you're talking about, is that even the right approach? Small employers, to me, small, medium size, are very interesting incubation labs for a different way to think about this, which is, can we gate it to a few MSAs and do a few pilots to understand who can be safely deprescribed? And the data now shows you can get gains, Kirk, within 6 months. If you're a type 2 diabetic, and I would say somebody with multiple underlying chronic conditions, a type 2 diabetic, hypertensive, that meets BMI criteria, that is sort of the use case. Initiate them on a GLP. Put them into a rigorous program where then, with a clinical pharmacist, we always had sort of an obesity medicine specialist plus a clinical pharmacist that could potentially help think through things like safe deprescribing. Put them through that program where you're always looking at a certain point, once you've met certain clinical end metrics or end goals, A1C is normalized, you're off insulin dependence, whatever it is, systolic blood pressure is improved. Once you've reached it, what needs to be true to safely deprescribe? And maybe now, because we have oral options basically in the near future, a smaller, medium-sized employer says, you know what, we're going to try something novel here, which is we're not going to just deprescribe them and say, hey, good luck, go to the gym a lot and do all the things and sign up for, Omada or some sort of fitness app or something. We're going to say, hey, we're going to put you on oral. And I think de-escalating from an injectable to an oral makes a ton of sense from a price point perspective, maintains their gains potentially. But these are the types of pilots and experiments. Again, going back to our point on better screening tools, we can't just keep thinking about things in the same way, remessage it, repackage stuff, and hope that people are better, engaging, or that we are having different outcomes if we're just saying BMI of 45 or, hey, we're not going to cover it. I do not think an employer of any size can say we're not going to cover it or we're just not going to engage.
Super, super insightful. And I'm hoping that employers are able to kind of figure out how do we kind of manage this price point thing. And I'm super excited about the concept of the orals coming out and being at a lower price point as well. But I thought the idea of the pilot was really genius too. So that's awesome. So I want to kind of wrap on this. You've talked about the idea of being a physician communicator and some of the challenges that are associated with it, including from your own peers. So what got you motivated to do public health communications? Tell us about some of your experiences being in the public eye, giving a point of view during COVID and as a physician and as a communicator.
I know a lot of young health professionals see the gap between the mentorship they get in the four walls of an academic environment that tells them that the only pathway to success is if you go into a research career, or if you do X, Y, and Z, which is some version of an ivory tower sort of defined version of success, which is publish papers, see patients. Fine. That's totally fine. It's also wrong. That's not the only way to have success and impact beyond the bedside. I think we all in medicine, I constantly meet people that are looking for ways to scale their impact beyond direct patient care, beyond the bedside, which is admirable. And I do whatever I can to help provide mentorship. I know many that have done different career paths in tech, whatever it is, are trying to do something similar. But our mentorship paradigm in healthcare is completely off base, and it's highly judgmental about what is and is not considered a successful, impactful career. So that's number one. Our incentives are not in place for people to take risks, and that's bad. I did not move to Seattle, Washington thinking and or in any way desiring to be doing public health communications. So you stay in New York City or in the Northeast, even from a time zone perspective, since that's the news capital of the world.
This morning I
was up at 3:30 a.m. talking about measles and bird flu. And I went from being gun shy about it, because I think in medicine, you're taught to keep your head down, do your job, don't draw attention to yourself. Fine. The reality is, there are forces that have nothing to do with science or clinical medicine or the quality of the care that you're providing at the bedside, good doctors providing good value care. There's so much that's extraneous to that is impacting the provisioning of care in the United States. And you know exactly what I'm talking about, as do your listeners right now. It's politics, it's our information environment, it's where people get their news and how they perceive things. And perceptions, especially in the digital environment, are defining a lot of, what's happening with the measles outbreak right now. A lot of people are not presenting to care. We talked about early treatment, the golden window of care. A lot of people are delaying treatment because they don't think they need it. It's maddening. And so this is a long tee up to say, I didn't ask for this. I didn't think about it. I didn't think that this was in the cards. I've realized, though, that there's some measure of trust. It's my way to have impact beyond the bedside, potentially, and is perhaps maybe the most important thing I'll do. And so going from being gun shy about it and a little coy to now fully embracing it, I am fully embracing it, because I do think we need people to meet this moment. And I will say the misinformers out there have megaphones. They're all amplifying each other in the digital arena. And those that are trying to do the right thing are still playing it safe. They're still playing it by the book. They tend to not to be in the digital arena, and they tend to keep their head down and not speak up. And we need to have a different paradigm.
Vin, we appreciate what you're doing and enjoy listening to you. And more than anything, just really appreciate you being here today with us.
Thanks a lot. Thanks for having me.
If you're liking the conversation, be sure to subscribe so you don't miss future episodes. And if you've been enjoying Margin of Care, please leave us a review on Apple, Spotify, or wherever you listen. If you've got feedback or questions or something you'd like us to cover on the show, send us a note anytime at marginofcare@getgarner.com. We'd love to hear from you.